Hi guys, this video is about MCL strains or medial collateral ligament strains of the knee, which is the ligament that runs over the inside of your knee. What I'm going to look at is the anatomy, the mechanism of injury, because if you understand the mechanism, you'll know why you need to avoid certain things during your recovery period. We're going to look at healing times. How long can you expect it to take to get better depending on what else you've injured together with the MCL. And then lastly, I'll talk you through the treatment process and specifically the rehabilitation exercises. Good, so my name is Maryke. For those of you who don't know me, I'm the physiotherapist from sportsinjuryphysio.com, where you can get online physiotherapy assessment as well as treatment of your injuries. So have a look at the description of this video if you want a link to the website. Now, anatomy of the MCL, and it's interesting because things always change with regard in medicine and physiotherapy and things as we learn more. So even for the medial collateral ligament, the MCL, we've now realized that actually it's more than just one ligament there. When I studied, I'm pretty sure we only knew about the superficial and the deep MCL ligaments. We didn't know about the posterior oblique one. So you'll notice there, that's a picture of your knee on the left-hand side, kind of looking from behind at an angle at your right knee. So what it's showing is those two ligaments, the S stands for superficial, at the front, that's your superficial MCL running there. But then you've also got a fat one that comes to the back kind of, and that's the posterior oblique ligament. And both of those work really hard to give you loads of stability on the inside of your knee. And then if you cut them away and take them fully away, you'll notice that there on the right hand side of your screen is a tiny little ligament that's deep, and that's the deep MCL. And that attaches also to your meniscus, the medial meniscus on that side. Now, for interest's sake, this is just for clinicians really, it's academic importance really, is what they've shown, or what they have shown more consistently through the research is, you know how you test for the MCL with the knee fully straight and you provide the valgus force, and then you test it with about 20 to 30 degrees bend in it. So what they're saying is, if you find it's lax in both those positions, especially the straight one, it's more likely that you've torn the posterior oblique ligament as well. Whereas if you only have pain and laxity in the 30-degree knee bend position, it's more likely just the superficial MCL that you've strained. But to be honest, that really doesn't matter for to know specifically like that for your treatment, because treatment is according to symptoms and according to what the patient reports for you. So it's just for interest's sake. Good, so the mechanism of injury. Now, if I can demonstrate this to you, it's very much mechanical if you think about it. Let me just get this thing out of the way. There we go, that's better. So if we look at the knee, and you can picture that ligament coming over the inside, or those three ligaments stabilizing the inside of the knee. So it's forces that push the knee from that side that's going to force it into that position. You'll see that that's when they're really going to have to work. So usually you tear it if there's either impact from the side, or if you step off something and your knee suddenly goes into that position and it wasn't ready for it. It's anything where you get a sudden force inwards. But you can get a chronic strain as well, where because of the way you walk or the way you run, if you don't have good stability around your pelvis, or your foot just collapses too much, you're constantly, the knee's taking more strain on the inside, rather than taking it through the leg in a position where it's distributed more evenly. That can actually cause a chronic strain of your MCL as well. And that's quite a common one that you can see in runners or walkers if the pain comes on over a length of time. And we'll talk a little bit about that more where rehab is concerned. So why is it important to understand that it's those strains that makes the knee turn in that usually causes the injury? Because, especially during the first few weeks of treatment, you want to avoid forces that pushes the knee in or makes it carry more weight on the inside, because you want the ligament to knit and the fibers to heal. So keep that in the back of your mind. Now, also because of the mechanism of injury of it usually being forced into a valgus force and a bit of rotation, you can also get it's quite common to get ACL, so anterior cruciate ligament, and a medial meniscus injury together with an MCL injury. But it is totally possible to have a pure medial collateral ligament injury on its own as well. So healing times. Luckily, your MCL actually has really good blood supply, especially the superficial one. So they heal quite quickly for a ligament. And the healing times for your MCL, if it doesn't have anything else going on, is between 4 to 8 weeks. So 4 weeks for a less severe one, 8 weeks for a more severe one. But because of the mechanism of injury, you can injure your meniscus, you can injure your anterior cruciate ligament as well. And as soon as you've got those two together with the MCL, your rehab time will be a bit longer. Another thing is you can get bone bruising. So during that force where especially if it's a traumatic one, where you get a sudden sharp pain there because of something you've done, the bone surfaces can squash together. And you can get a bruise in those bones just like you can get a bruise in other parts of your body. And bone bruising takes longer to heal than the ligament itself. So your pain can persist for much longer. So it may take about between 2 and 4 months for that bone bruising to go. So you may still get pain in that area, even though the ligament has already healed. That's where it can be useful to have scans, because it can explain why your pain is carrying on longer than what you expected to carry on. But honestly, for a pure MCL strain, I don't tend to send my patients for scans for that, because you can easily diagnose it through the history they give you and certain movements and things you do. And the healing time, or the healing process, is quite simple, to be honest. So if we look at treatment, the treatment approach for this will depend, as with most things, very much on the severity of your injury, and also a little bit with regards to the mechanism of the injury. So if we think that it's a chronic overuse strain instead of acute tear, you maybe focus on rehab around the hips and things a lot more initially and get them going quite quickly with the overuse one. Whereas when it's an acute tear, you want to maybe protect the knee a little bit more, and it may be secondary that you look at the hip stability and things, that it's not that, because it's not part of the initial injury or the injury mechanism necessarily, that they have the acute tear. I'm not sure if I'm clear there, but you'll see in a minute what I mean with that. So we get roughly 3 grades of MCL tears, where grade 1 is very minor strain, grade 2, significant number of fibers that's torn, but not that many. Grade 3, it's fully off, so you've got quite a bit of instability there. Now, even grade 3s that's fully torn off does really well with conservative management. And the research is definitely on the side of conservative management here, that you do not have surgery before you've tried conservatively to get this better. You don't necessarily need to use a brace, but braces can be very useful, especially if you've got a grade 3. So they used to stick people in plaster casts and really rigid braces where it doesn't allow any movement of the leg, thinking that that will help the ligament to knit and to heal. But loads of studies have now shown that you do not want to immobilize that leg fully, because if you do that, actually you mess with the collagen turnover. So you're getting the collagen that replaces the torn fibers in that ligament is of a poorer quality, they're not as strong, and you get fewer of them being formed. So you're much better off being placed in a hinged brace where the knee can move forwards and backwards, but the side-to-side motion is limited to an extent. So it's got those hinges on the sides, and you can immediately start weight bearing, because what they've shown with that is that actually stimulates the collagen to be produced much more quickly. It helps to realign that collagen, because remember the first, if you've listened to any of the healing videos that I've made, initially when new cells are formed to replace injured ones, they kind of just formed randomly, that they're not organized properly. So through careful movement, the body realigns those fibers in the direction that it needs it to be, and it strengthens it. So using a hinged brace, really good for grade 3 especially, but rigid braces and full leg casting should be totally avoided. Now, how long to wear a hinged brace when you've got a grade 3 tear is also a little bit up in the air still. So some studies have worn it for 6 weeks to help stabilize that, whereas other studies on younger players, so these were school students, they only wore it for 1 week before they took it off and did their rehab properly, or moved around without it. I think there's 2 things that would guide my, well, there's 3 things really that will guide my decision with regards to that. One is if it's a really, really, painful knee, and the extent of that grade 3, if there's any other things that you can tell that is just making that knee feel a bit more unstable. And if the patient reports to you that it feels really unstable, I would probably wear that brace for a longer time rather than a shorter time. Second, the age of the patient. So it was basically kids that only wore it for a week, and kids recover really quickly, whereas adults don't recover that quickly because their bodies don't replace cells that quickly. So I guess the younger population may get away with shorter bracing, whereas older people may need a little bit longer bracing. And then thirdly, and probably the most important factor for me for how long I would get somebody to wear a brace, is the symptoms they report. So if they're really comfortable, that knee doesn't feel as if it wants to give way, they can do their exercises without the brace on, really good, without any sensation of giving away, I would start weaning them off the brace. So there's no clear cut, you have to wear it this long, but make sure if you're going to use a brace, it's definitely a hinged brace and not a solid brace. Then also, they need to take the brace off when they do their exercises. So if you're doing your rehab exercises, it's without the brace on, because you want to teach that leg the stability and how to control it properly. Of course, within the first week, if it feels really unstable and you don't feel secure on your leg, absolutely do it with your brace on. But you need to start doing your rehab exercises after that very carefully without the brace on. Okay. Braces are really just there so that when you're walking around outside and you're doing activities where you're not necessarily 100% concentrating, or there's a chance of somebody bumping into you, that it gives you that extra support. I haven't used braces much in my career so far because for most people, a brace is really uncomfortable. So especially for my older patients, when they come in, and these braces are bulky, if you're wearing a brace that gives you proper support, they're really bulky things. They don't always fit everybody's thighs properly. So I would tend to rather explain to them that it's really, really important for the next 1 to 3 weeks that we avoid that valgus force, that turning in force. So we could put you in a brace, but if you're going to be really careful and make sure that you don't walk on uneven ground, don't get a hit from the side or anything like that, then you can get away without wearing a brace. And normally, if I really explain to them to avoid those twisting actions, avoid any uneven ground and things, they're very good at looking after those knees. And I've not had anybody injure themselves through that. And they've been able to get away without wearing braces. If, however, it's a really unstable knee, I would make them wear a brace. Now, let's see. So early weight bearing is important. We've spoken about those. Okay, so if we look at rehabilitation, your first aim with a torn MCL is to get your range of movement of your knee back. So flexion and extension. And it's as easy as just gentle movements. I tend to tell my patients for the first day to just let it settle. So I won't get them actively moving things. I'll tell them to move it as you feel you want to move it. But from day 2, I get them to do bend, extend, bend, extend. Usually on the bed is quite comfortable because you can support your leg and just gently extend and bend, extend and bend. But you can do it in sitting where you just, and in sitting it's got an added benefit that you get your quad muscle working then, where you just extend your leg. Can't really see that, can you? Hold it, hold it, hold it, and bend it. And often for the MCL, straightening the leg can be more painful than bending the knee actually. So you don't force it within that first period. You do what you can do with it, but you try to get your full range. Now, if you've got a mild strain, you could get that full range within a few days. If it's a more severe strain, it may take you a week or a little bit longer than that. but just keep it moving. Get that full range through that knee. You also want to start working on getting the quads firing. So that exercise I've just shown you, where you just extend the leg, hold it there for a period of time, bend it back, can be a brilliant one to start getting that functioning. Then also we want to use it in a closed chain position, because that's open chain. So when we walk is closed chain because your foot is planted, and then you go down on your foot and you propel yourself forwards. So things like, this is all early stage, by the way, guys. So for early stage, to get that done is just slow double leg squats. But you'll notice that I'm not necessarily even going low. You just go to where you feel comfortable to do it. Hold it, hold it, hold it, come back up. But now remember, this ligament's job is to provide stability on the inside. So you want to now start teaching the rest of your body to control that knee properly, so that the poor ligament doesn't take all the strain. So when you're doing a squat, it's not just about going down and up. It's about thinking and looking at where your knee's moving. So knee move in line with middle of toes. So you've got a nice straight line. So you don't want to see them moving in or moving out as you do that. So start using these early stages to teach yourself that movement pattern. It very much depends on your foot stability as well as your strength of your glutes, where your leg's going to move when you're on one leg and when you're walking and running. So you can also in these early stages start working on glute strength. So stuff like double leg glute bridges, side leg lifts, all of those low load exercises that can just get the glutes firing and start getting them awake or waking them up. Balancing exercises, super important, but depending on the severity of your strain, you may want to wait a few days. Others can start immediately. So when you balance, you definitely think about not allowing that leg to move in or out. And when we think of balancing exercises, it's not boom, go into the most difficult one you can think of. I tend to really get my patients to just, they think about their pelvis alignment standing on 2 feet. So this is straight. Then you slowly shift your weight over. Tend to have a little knee bend when I do that. And then you just lift the other leg a tiny bit off the floor. So that much. Whoop, that much. So it's not getting up in there, because often when people do that, they start going all over the place. So make it quite nice and safe and easy at the start. And you want to see that this leg is nice and solid. And you just go for 5 to 10 second holds before you rest. Eventually you want to build it up to 30 seconds or whatever you can do, closing your eyes, turning your head from side to side. You can even do things then like single leg deadlifts and stuff, where you really make it difficult to keep your control. But always the idea is that knee needs to stay in perfect alignment, that it's not turning in, and foot needs to stay, that it doesn't roll in, because that teaches you control again. Okay, so that's kind of the starter exercises. Then from there on, we need to work on control or strength of the quads, strength of the hamstring, strength of the glutes, calf strength. So you can start with all of those exercises at whatever level you can feel doesn't impact your knee. So if you've got access to a gym, brilliant, because you can already start with quite heavy knee extensions as soon as you've got the range, leg curls, calf raises, because none of that will affect that ligament directly if you do it with good form. You want to be able to do squats through full range eventually, and you also want to build up to doing them with quite a bit of weight extra. Once you can do that, you have to move on to single leg stuff. So because when you run and when you walk, you don't do it on 2 legs at a time, you do it on 1 leg at a time. So you need to teach your body that control again. So the order in which we do it is you get your range of movement first, comfortable, then just body weight squats, nice and stable. You're happy with them, try body weight lunges, but you're not lunging into the position, you're literally assuming the position and just dipping in and out. But the whole time thinking about that kneecap aligned with middle of the foot, we're working in a straight line, okay? Once you can do those things easily, you add weight to it. And you see, can I build this up with a bit of weight? Then, from there, you want to make it a bit more unstable. So then you start working single leg squats or single leg supported squats, or single leg sit to stands from a chair is quite a nice exercise where you make it high enough and you try to get up and down on one leg, but you're keeping that knee in perfect alignment. Your choice of exercise will depend on the person in front of you. I mean, for my older patients who just want to garden and walk their dogs, I'm going to give much less athletic exercises than I am for the younger person who needs to go running and play football. Okay, and I won't necessarily train it to such a high and unstable level for the person who just wants to walk and doesn't do sport with their pivot and stuff. So as soon as you've got your control on a single leg in a straight line, then you've got to start adding in rotation forces, because that ligament needs to be able to withstand those. And again, it can be as easy as standing on one leg and pulley system that you pull, okay? Or lunging in different directions. Putting a band around your knee that pulls it into a certain direction while you're doing a lunge or a step up. All of those things can be really useful. Now, if you're doing a sport where you've got to run and you've got to change direction and stuff, you have to make sure that you first get back to jogging in a straight line and you're comfortable. So as soon as you've got your full range in your knee and you can do a nice comfortable squat, you can start with a run walk and just test that out. But remember, when you run walk as well, you want to make sure that you don't feel your knees turn in excessively. You're thinking about your form, knees pointing forwards while you're running, keeping your steps light. If you're comfortable running in a straight line, you have to start doing some gentle changes of direction. But if you're somebody who does an agility type sport like football, for instance, you'd start by just running slowly in a direction and slowly changing direction before you do it to the other side. And as you get better at controlling that, you speed it up, because the faster you do it, the higher the force. So you've got to do a few sessions with slow first. You want to do other agility drills like grapevines and stuff as well. But all of that, you start with slow and work your way up to fast. If you're just a runner and, oops, sorry, got a hair tickling my nose. Just somebody who runs, so you're doing distance running and things, so you're not really on about changing direction and stuff like that. You just start with getting back to easy running, easy pace running, thinking about form, because especially if you're running slower, it's much more easy to collapse into poor form with that. Then, oh yes, for the guys who does sport and quick changes of direction, and especially if you're doing jumping type things, you have to work in hops and jumps in different directions. So you'll start with double leg hops, straight directions, sideways and stuff, and then move on to single leg hops, because that's higher load. Good. So there was one question from somebody in the on my sports injury page where he said he had an injury to his knee about 10 years ago, and he had keyhole surgery for the cartilage, and that worked really well. And then 6 months ago, he twisted quickly and felt a sharp pinch on the inside of his knee, and he sent me a picture, so it looks as if he's pointing to the upper portion of the MCL. MRI scan showed absolutely nothing in the cartilage, and the surgeon suspecting ligaments. What to do? So what I would do with that is I would definitely start working on good glute strength. So starting with double leg bridges, working up to single leg bridges, thinking about your form when you do those. I would work on double leg squats until you're comfortable with them. Make them maybe into goblet squats and things to get some weight through that. And once you're happy with that, work onto single leg supported squats, where you really make sure your knee moves in good alignment, doesn't turn in or out, and it doesn't cause you pain while you're doing it. At the same time, you start working on single leg balance, that you get your balance really good, so that once you're good with your single leg supported squats and your balance, you can put it together and you can make it an unsupported single leg squat. That's then more taxing on your balance and your load through there. So yes, that's pretty much what I would do. Is I would work on really good glute strength, work on your supported movements first, that you get your pattern of your leg moving properly, and then quad strength and balance in single leg activities. And then when you do go for runs or walks, make sure that you think about where that leg moves. And if you feel that it's still turning in despite you trying to be good with those things, and you feel that it may be coming from your foot, it may be worth getting somebody to check if there's a bit of overpronation going in your foot, or maybe your shoe just needs to be slightly more supportive on the inside, that it doesn't allow so much turning in. So there's a few things to think about there. Excellent. Let me know if you've got any questions, and if you need more help with the injury, you're always welcome to consult me via video call. Link is in the description of this video. Take care.